Peter, ulikuwa unatakaje? Utengeneze alafu taniambie. Nimalize hii lecture. Niko around. Wote nimalize alafu tuongee. Okay. Ndio kusema niko na class.
Dr. Kiboi?
Yes, you can hear me?
Yes, we can begin now.
We can start.
Yes.
Thank you so much, Kim. Yeah, hello. Welcome to this lecture that I was going to give you. I'm sorry I was delayed, and I was with the principal, who is now our dean. You know very well what the changes have occurred in the university. So mine today is to give you an introduction to neurosurgery. This will be a topic which introduces it to interest you into neurosurgery, number one, and then maybe to give you a guidance of what really we do in neurosurgery. For the 4th years, I'm very happy that I'm really back and involved with the management of your teaching. And I'm talking to Khan and Chebet because I found out that a lot of you are not learning general or surgery like I would want you to learn. Number one, in 4th year, what we need you to know is just history taking and examination. So I've started a series with some of you, but I want to improve it so that you are exposed more to all the other lecturers in my department. So please, with Khan, I want you to identify all the leaders that will be in all the other units, in general surgery, Farm 1, Farm 2, Farm 3, also in neurosurgery. I want to take you to cardiothoracic surgery. And some of you came to the clinic on Monday, and I showed them what we need to do. And I think if I show you what you need to know, then end of the year will be very easy for you, because we really feel sad when some of you fail what you call junior clerkship. So I think in this series, maybe when we finish, some of you can ask me questions about the preparation of your examinations so that I see how to make sure all of you get good marks. So in terms of neurosurgery, let me see, in terms of neurosurgery, we cover a very wide base in neurosurgery. One, we touch on the brain, and the brain is where we have the main pathology, all right? And then also we have the spinal cord, and also we also discuss about the peripheral nerves. The peripheral nerves, a lot of times we don't see them in our setup. These are things like what we call the carpal tunnel syndromes, the brachial plexus injuries, and things like that. A lot of neurosurgery involves more of the brain. And because of that, we as neurosurgeons feel very close to what we call the supernatural life, because many years people believe that the brain is what carried your soul, or the brain is what carried your life. And it's true that as we are involved in operating the brain and sometimes the spinal cord, somebody can live or somebody can die. And it's a mistake in terms of what really is in the brain and what really is in the mind. What is this thing that God has put into the brain that you are alive? What is this thing that God has put into your brain that when you sleep, you find yourself into another world, then you wake up and you actually don't know? So this particular picture shows you where Jesus was laid after he was hanged. And that's why we will find a lot of neurosurgeons are very religious, and is in medicine also. You'll find quite a number of us believe in God, whether it's in the Hindu culture or in the Muslim, in terms of believing on Allah. There's a direct connection. And this is because the understanding of the brain is very, very complex, and is because of what we deal with. It changes your personality, and I'll explain to you as we move on. So this is a very famous place in Israel, which I'll explain to you later. Now, in terms of neurosurgery, you must have a good teacher. One of my teachers is Professor, and Professor comes from Israel. He was a very good Jew, very, very strict. he taught me a lot of neurosurgery. He's now based, he was in South Africa initially, and now he's based in Israel, in Jerusalem. Now, what do teachers teach you? One of the things that you learn from a teacher is not only character, but the fortitude, how to be strong in your field. But as a teacher, that's why I want to be directly involved in your learning and teaching, because unless you have a very basic foundation, then it will be very, very difficult for you to survive in neurosurgery. One of the things he taught me very well is to stitch. How do you stitch a simple wound? You know, when I went there, you know, I thought I knew how to stitch, I knew how to operate. But when I was there, he would say, Kiboi, you know, this way they didn't stitch well, open it up and suture again. So sometimes you might see us very obsessed. The teachers can be very obsessed. We have what we call obsessive compulsive disorders. But it's because neurosurgery is very, very meticulous. And it involves a very long learning curve. Now, most of you in 4th year, by the time you finish your 6th year, you'll be saying, I don't want to come back to school. But I assure you that specialization is the way to go. All right. Obviously, would want some of you to be politicians, would want some of you to go to parliament, to be senators, to be governors, to change policy at another level. But when you look at it from a teaching point of view as your teacher, is for you to come to medical school, you can finish medicine and go and do something else. Like you can do MBA, you can do so many other things. But those other people, the people in MBA or in arts, can never do medicine. It's very difficult. So it's a God-given gift for you. And that's why I want a very keen interest in forming you to be what you'll be in the next few years, where you'll join this very noble profession. And my interest today is to show you how neurosurgery is so sweet and so enjoyable. Neurosurgery is a difficult career, but it is enjoyable. You know, when you operate somebody who has been paralyzed, it's like seeing a flower, you know, blossoming. So why is it enjoyable? Because everything you want to do must have passion. If you have passion in whatever you do, then you'll succeed. But imagine seeing a patient who was not able to walk, and then that patient walks. But it can be difficult. One of the years, about 3, 4, 5 years ago, one of my professors in gynecology had a son who was very interested in coming to neurosurgery. Now, when I took him to theater, because the father is a gyno and an obstetrician, when I took this young boy, he was, I think, in 5th year, and I was trying to interest him into neurosurgery. When we went to theater, that patient post-op didn't do very well. He started having fits while operating. Then there was a bit of like bleeding. And then the patient died, you know, because sometimes you deal with a situation where whatever you're going to do, you can't change much. So the patient eventually succumbed and died. And my friend's son could not live with that. Immediately he said he was not going to do neurosurgery. So you can see the challenges we have. And then he said, no, you know, gynecology and obstetric is very enjoyable because, you know, when they see a baby being born, the joy it brings to the mother and the obstetrician is enormous. But for us, sometimes we deal with a death and complications kind of situation that it can be depressing. So from that time on, I lost that student and he went on to be a gynecologist and obstetrician like the father. So I'm not showing you that it's difficult, but I think it will take in a lot of calling and a lot of me teaching you that the complex things are also gratifying when you have very good outcomes. Now, we have fathers in neurosurgery. And one of the fathers I would like you to go and read about is called Harvey Cushings. Harvey Cushings was based in the US. He lived in the 1800s and came up to be one of the best neurosurgeons in the world. He's the one who changed all the outcomes. Now, one of the things about Harvey Cushings, he was a fighter. He was very aggressive. He fought in with a man called Halsted. You're going to read about Halsted, who really got involved with the total mastectomy. He's the one who went on into teaching of breast surgeries. But Harvey Cushing's and Halsted had a very big altercation, because when Harvey Cushing's was operating, a lot of these patients also were not doing very well. But Harvey Cushing became persistent. He was involved in neuroanatomy and in the teaching, and became now really one of the big fathers of neurosurgery in the world. He's the one who prioritized all the syndromes you hear sometimes of Cushing's reflex. Sometimes you'll hear of Cushing's syndrome. They're all very different, or even Cushing's disease. So he lived in Boston. He worked in Massachusetts, where he was one of the great teachers in Johns Hopkins Hospital and also in Harvard. I'd want some of you to visit Harvard and see some of the great works he's done, because we have a museum there of Harvey Cushing's. And one of the biggest things I admired about Harvey Cushing was his handwriting. He was a very good artist. He knew even how to draw the brains. And if you Google, you'll see some of his drawings as he operated. Now, Harvey Cushing was based in the US, while Victor Horsley is also famous for neurosurgery. He was based in the UK, and they lived in around the same time. So the Americans were pushing in neurosurgery in America, and then Victor was pushing in neurosurgery in UK. And these two went on to compete. And actually right now, you'll have a lot of arguments between the UK and the US as to who was the best and who really pushed in what we call the micro neurosurgical techniques. Before, the operations of neurosurgery was very crude. They'd open up the brain and then use the fingers to remove the brain and palpations and so on. But Harvey Cushing and Victor Horsley changed to neurosurgery to what we call now the micro neurosurgery. This is where we use very fine instruments. We use forceps, we use what we call bipolar, and this is very meticulous. And it has gone on to change neurosurgery with the use of microscope, where now our outcomes are much, much better. The neurological deficits after surgery are very well reduced. Then locally, we had our Professor Mangombe. I think some of you maybe could have met him. He has since retired, but after retiring, he has been employed by KU, Kenyatta University on Thika Road, where he has gone into starting a program of M-Med surgery after retirement. So Professor Mangombe was our father of neurosurgery here for many years. He's the one who even has established and promoted the introduction of M-Med neurosurgery, which we are doing locally in our program. Now, why have I taken this picture? This is a famous picture of a man called St. Joseph. And the St. Joseph is believed, a lot of you, you know, in Islam, I think he has a name, Esau. I think he's called Esau. In the other religion, we call him Joseph, the worker. And why I'm showing you this picture is because neurosurgery is humbling. When you go in there, you don't know whether the patient will survive or come out. But the beauty about St. Joseph, he expounds the ideas of working, giving in quality work, number one. Number two, I can imagine him being a carpenter. He was a carpenter. And I would want to imagine, was he making tables which were not balanced? You know, you have a table with 4 legs. And then normally some of these tables, you have to go in and put in a paper under there. Now, neurosurgery, you cannot invent your own ideas. One small mistake will be a disaster. And this is what we really need to teach you in terms of neurosurgery. Now, in neurosurgery, are you going to come to do neurosurgery so that you can have expensive cars? All right? Are you going to have neurosurgery so you can buy Ferraris? There's this big notion that when I'm doing neurosurgery, I'll make in a lot of money. And let me tell you, my young colleagues, you're not going to make money from medicine. Medicine is a noble profession that you're supposed to help patients. But in the process, when you become very good, you'll make in a little money to survive, to maybe have a good home, you can have a good car, but you're not going to have flats. You're not going to have very many houses all over, unless maybe you join politics or some other business. So don't come into neurosurgery thinking, wow, I'm going to buy a Ferrari. I don't know how much is a Ferrari now, Khan?
Like $2 million.
$2 million, yeah? What of, do you know another car called Corvette? Corvette. Corvette is a Chevrolet sports car. Have you
Yeah,
ever heard
Corvette.
of Corvette? Yeah, Corvette.
Yes.
Maybe it's like 100, maybe 100 or another $200,000.
Yeah.
So I don't want you to have a wrong notion. You'll see some of my neurosurgeons here maybe drive big cars and so on, but it has taken many, many years. So I want you to learn neurosurgery is not something you're going to go in. It's true. In neurosurgery now in the market, if you operate a patient with a meningioma, you'll easily charge 150,000 or 200,000, depending on the hospital. But in reality, you cannot operate more than 10 patients in a day or 10 patients in a month. So it's not like any other field in terms of ENT or another field like gynecology or another field like ENT or plastic surgery. You know, plastic surgery is only maybe in our country, but it's also coming up. Plastic surgery, I've met the plastic surgeons in the US, in California. They are extremely wealthy. They all live in Beverly Hills. They even have helicopters. But neurosurgery is different. In the US also could be paying, that is possible. But in our local setup, our patients are poor, and then you remember how our economy is. So I'd like to interest you in surgery, but not where you think, I'm coming in so that I can make in a lot of money. Now, in terms of head injury, I would like you to know really what is the main particular intention for us in terms of head injury. For me, and at your level, we just need to know the causes and how to take in the history of presenting illness and a bit of the examination technique. Now, head injuries are very, very common. So it's something you've got to understand in details, because even when you qualify as an MO, you're going to be exposed to a lot of head injury cases. Now, I did a study myself in my thesis where I reviewed the head injuries in our Kenyatta National Hospital. And what I would want you to concentrate on is what we call the severe head injuries. And among the studies I did, of about the 600 patients I saw with severe head injuries in 1999, 1998, about 50% of those patients were dying within the first 24 hours. In the next 48 hours, about 60% of them were dying. And therefore you ask yourself, what are we doing wrong in managing the head injury? At your level, what would be of interest? At your level, my interest would be that you are aware about the Glasgow-Coma scale. Now, the Glasgow-Coma scale was formed by a man called Brian Jennett and Tisdale in Glasgow, all right? So you don't say Glasgow-Coma scale was discovered by Glasgow. No, it was discovered by Brian Jennett and Tisdale in 1974, and I'd like you to go to the library and dig this particular article. It's there in the journals, so that you can understand why did they come up with the Glasgow-Coma scale. The Glasgow-Coma scale is what we use to measure the level of consciousness in head injuries. So it was used as a way of communicating, all right? So if you have a patient who is in coma, there were so many vocabularies that had come up. One of the vocabularies was the patient is obtunded. Then another one, or the patient is semi-conscious, or this patient is drowsy. So in terms of communication, it was very difficult to say, what do you mean by a patient is obtunded? And when they came up with a Glasgow-Coma scale, they measured 3 variables. And one of them was eye opening. The second was motor, the best motor response. And then the other one was a verbal response. Now, I don't want to teach you about the Glasgow-Coma scale. I'll teach you this in the clinic. But the Glasgow-Coma scale was therefore used up to a scale of 15, and we divided it into severe head injury, moderate to mild head injuries. Now, your concern should be the patients who are very seriously ill, and they're the ones who have a Glasgow-Coma scale of 8 and below. Now, Any patients who have a Glasgow Coma scale of 8 and below must be admitted in ICU, number one. Number two, that patient must be intubated. Number three, the patient will need the ventilatory support. And then elevate the head to reduce the brain pressure. So head injury is a common topic you're going to learn, but this Glasgow Coma scale has advantages and disadvantages. One of the biggest disadvantages about the Glasgow Coma scale is the pupillary reflex. All the patients who come in with head injury, you must do a pupillary reflex. You must see whether the pupils are equal, whether one is dilated, whether they are reacting to light. That alone will tell you the status of the brain and the status of any intracranial head injuries. So the Glasgow Coma scale does not include pupillary observations, and this is what I need to teach you. Number two, the Glasgow Coma scale does not give you whether this patient is hemiplegic or paralyzed. And lastly, the Glasgow Coma scale does not tell you whether the patient has epilepsy or no epilepsy. So it's a very good scale to measure the coma scale, but it has its own advantages and disadvantages. One of the biggest advantages is that you can communicate. When I tell you this patient, the Glasgow Coma scale is 8 or 10 or 15, even if you are on the other side on the phone, you can understand what you're talking about. The second thing I want you to look about are brain tumors. The commonest brain tumors you're going to see in our setup are meningiomas. All of you must understand what we mean by meningiomas. These are neuroepithelial tumors. They mainly arise from what we call the arachnoid gap cells. All right, the arachnoid has the arachnoid villi, which give you the meningiomas. These are benign tumors. All right, a lot of times you'll hear us talking about meningiomas as grade 1. Rarely will they be grade 2. The way we divide meningiomas is you can divide them through a histological diagnosis, number one. And number two, you can divide them using what we call radiological studies. Now, it's very difficult to give you a lecture of meningiomas, but is to give you an example, some of the meningiomas can be in the sphenoid wing. So we'll call those sphenoid wing meningiomas. Then some of the meningiomas might be in the foramen magnum. So we'll call them foramen magnum meningiomas. So the location of the meningioma classifies them. And then that classification gives you the degree of difficulty as you operate them. A lot of meningiomas histologically are low grade. You will hear us talking about transitional meningiomas. You will hear us talking about epithelial meningiomas. So there are different classifications depending on whether you're using histological classification or anatomical classification. Now, gliomas are one of the biggest research interests now in the world. Gliomas are divided into grade 1, grade 2, grade 3, up to grade 4. So the gliomas, which are grade 1 and 2, are classified as low grades. Then the gliomas, which are grade 3 and 4, are high grade. Now you'll hear us talking of a high grade glioma, which is grade 4, and a lot of you will hear the name glioblastoma multiforme. That is one of the worst tumors we have in the world now. And I'd like some of you to be interested in these gliomas because the glioma grade 4 kills the patient within 6 to 18 months. So it's one of the areas now we are looking up in research in terms of the level of gap in the knowledge in terms of management of these very wild tumors. Then we have vascular tumors. And of the vascular tumors that are common, we have what we call the AVMs. All right, the AVMs, those are arteriovenous malformation. And the other one, which we call the cavernomas. And the vascular tumors are the ones for you as you are concerned when you're taking in the history and you have a patient who has a sudden severe headache or a sudden collapse or a sudden neurological change. Those are patients who you have to think vascular. Vascular events occur suddenly. So in your history taking, these are patients who, when you see a vascular patient coming to you, you'll have more of a diagnosis and be very sure that this is vascular because of the suddenness of the symptomatology. When you talk about meningiomas and glioma, these can be a slow-growing tumors, and they can give you more time vis-a-vis the other one. So further on, we divide the tumors, whether they are supratentorial or infratentorial. And then, like I've explained to you, when tumors have been there for a long time, the headache will be there for a longer time, vis-a-vis a headache that is sudden. This is a bit different from infections, because in infections, the patients will come in with fever, the patients will come in with a bit of other symptomatology that are related to infection, like TB, or maybe sinusitis, or even an abscess, or sometimes a lung disease that could have been metastasized from an infective point of view. So a lot of time, the tumors can be primary or can be secondary. The primary tumors are the ones I've explained to you. They are the meningiomas, all right, the gliomas, and any other vascular tumors. So when you think of the brain, think of the cells that are inside. Think of the meninges are the ones which give you the meningiomas. Then inside the brain itself, we have the neurons and the glial tissue and the ependymal cells. All those are the ones which give you origin to some of these tumors. Now, when you see a patient presenting to you with vomiting before the headache comes, then think of a posterior fossa tumor. They are infratentorial tumors. These are tumors which will attack an area we call the area postrema. All right, it's near the fourth ventricle, and therefore they'll present to you earlier with vomiting. So vomiting and a headache, you'll be inquiring from the history of the patient and know, did the headache come first or the vomiting come first, for you to be able to sometimes make up a diagnosis. Then vision gives you an idea of where this tumor is. If the tumor is in the brain and has been there for a very long time, and then causing what we call increased intracranial pressure, those are tumors that will cause papilloedema, and therefore patient will present to you with blurring of the vision. If it goes in for a very long time, the patients become blind because the papilloedema has changed from being a papilloedema to an optic atrophy. So when the optic atrophies, the patient becomes completely blind, which is something we need to communicate to our population, because if it's something that we had removed earlier, then you'll save this patient from becoming blind. When you see a patient with ataxia, all right, ataxia means instability in walking. The patients are walking with a wide gait. The patients are walking with a poor balance. They're walking in like they are drunk. Then think of the infratentorial tumors. Most likely, those are tumors in the cerebellum. And depending on whether it's achy-cerebellum or neocerebellum, I give you an example. When the tumors are at the center of what we call the vermix, they'll present with ataxia of the upper body, or what we call the trunk. But when the tumor is in the cerebellar hemispheres, the patients will present with dysmetria. Dysmetria means they can't work with their hands. So you'll hear us asking you whether you know about past pointing, the finger nose test, that's what we call it. You'll hear us talking about dysdiadochokinesia, all right, where they play with their hands. And then you'll hear us talking about the heel shin test. So there are tests which are for cerebellum, and there are tests which are for cerebrum. So you're going to learn all these things as we move on, but we'll teach you also as you progress. Now, epilepsy is a very common presentation of patients with lesions in the brain. But when patients have epilepsy, it most probably means the lesion is in the frontal lobe or the temporal lobe. But a lot of time, it means this lesion is affecting the cortex. When a lesion affects, like you can see in the picture there on the right side, this patient will present, this is a patient I operated. You can see how clean it is. We remove the tumor, but you can see how the cortex, and I've been able to save the vein, a vein that is on the surface, and the brain is very well relaxed. But this patient will have epilepsy because the cortex has been involved. So when a patient presents with the epilepsy, you go to find what form of epilepsy. So there are different types of epilepsy, which will also teach you as we move on. Then there are patients who will come to you with congenital problems. All right. I don't know who do you think, who can diagnose for me what this problem is? Any suggestions? Can you select one person to tell us of the diagnosis here? Hello, can you hear me?
Yes, Doc.
Yeah, what is the diagnosis here?
Castro can try.
Yeah? Castro.
Castro,
Yeah.
yes.
Castro, can you shoot? Can you try? What do you think is the problem here? Castro, can you hear your voice? Yeah, somebody has
Yes, written spinal bifida. Sorry, I we can unmute.
Yeah, very good. Somebody has said spinal bifida, and this is correct. Imagine, this is a patient who has had a spinal bifida for many years. All right, these are cervical spinal bifida. All right, and in this cervical spinal bifida, this particular one would be what we call a meningocele. All right, it might even have a bit of fat in it, so we'll call it lipomeningocele. So a meningocele has only the covering and the dura, vis-a-vis what we have, what we call a meningomyelocele. Now, when you see a mass like this in the clinic, you'll give the location, all right, it's cervical, posterior cervical. Then you'll ask for the history. You can see this has been there for a very long time, number one. And then you'll ask whether it is painful or painless, all right, whether it affects the upper or lower limbs in terms of weakness, number one. Number two, when you're examining, you look at the location, you measure the size of the neck, all right, then measure the length and the width. Then on inspection, the idea is to look at the skin cover, number one. Number two, look whether there are any vascular markings. And you can see on top here, you can have what you call some venous engorgement. When a lesion has a lot of vascular marking or vision engorgement, it's a sign of maybe it's a malignant tumor. So that's why vascularity on a mass is very, very important. And then you'll mention whether the tumor is regular or irregular. So you can see some of this has irregular surfaces. And then is when you go into palpate, and on palpation, you'll feel it is cystic. You can use a torch to look for whether it's translucent. And then as you palpate, you'll also see whether it's tender or non-tender. And then how fixed it is to the base, and how easy it is to move, and see whether it has a good skin cover. A lot of these spinal bifida sometimes have an opening behind. And when they have an opening behind, it's very easy to have CSF leak, which can give these patients meningitis. So you can see some of the problems you're going to deal with. The other common problem is hydrocephalus, which is very, very common. But we are very advanced here now. We're able to do shunting, and then we're also able to do what we call endoscopic third ventriculostom. So our country is very advanced in management of this patient. I hope one of the days I'll get this patient and operate him. He's from a poor family. We hope one day we can do this and reconstruct, because this is a person who in the village, I'm sure people run away from him. So this is how tumors look like. It's a very complex thing. And you can see how sometimes the tumor try to protrude through a surface. You can see here how we have very good brain, all right? And then you can see how the other part of the brain looks very weird. This is more of a glioma. You can see sometimes the interface between the normal brain and the abnormal brain is very, very clear. You can have a very clear demarcation. Sometimes the demarcation is not very clear. Then when you see this increased vascularity, it tells you that this tumor is very malignant. Sometimes tumors will have what we call necrosis. And that is why when we operate this, you need to find out your channel of relaxing. And the channels can be spots. The channel can be going in and having friends. But when you operate this, the tension is so high. You'll hear of us talking of, you'll have palpitations as you operate. Your blood pressure can go up, all right? Because you're dealing with a situation where the patient can come in. In this particular case, the motor strip was here, all right? You can see here the sylvian fissure, and you operate this and the patient can become paralyzed. You remember the sylvian fissure with the central sulcus, So as you operate, you're dealing with a patient who can get hemiplegia, number one. Number two, the patient can die. So you all have to find ways of what do you do as you finish this swab. And this is where, as doctors, you have to be very careful, because if you're not careful, a lot of you will end up drinking, will end up in a very wrong company, and you can find a famous doctor, going down because of how do you cope with your stress. Neurosurgery is so advanced. This is what we call an MRI. An MRI is very good. We use what we call magnetic resonance imaging. It's a very good machine, but MRIs are not for emergency, but is very good for tumor location, anatomical diagnosis, and gives you a wider definition in terms of diagnostic. Now in Nairobi Hospital, we also have an MRI with what we call neuronavigation, which can really target the tumor as you operate the brain tumors. In this particular one, I just wanted to show you the machines we use, and they're all available. This particular machine, we don't use it like for head injury. You only use it for head injury in situation of head injury where you are not seeing anything in the CT scan. Because an MRI will take you about 1 or 2 hours to do it. It's very expensive. And normally MRIs are not run at night. They are closed at 5 o'clock. So it's very difficult to do them as an emergency. Then obviously we have the CT scan. And the CT scan are axial cuts. They're done in axial cut. The CT scans use X-rays in 3 dimensions. Normally you have cut sections, what we call the axial cuts. So you can have axial cut. You can have what we call sagittal views. And then you can also have coronal views. I didn't put here, but I want you to understand the CT scan and how we do the CT scan. Now, in terms of MRI, we normally discuss any pathology in MRI in terms of hyperintensity. So anything that we look in like CSF is hypointense. Anything that will look white, all right, would be hyperintense. All right, like you can see here the hyperintensities. We call them hyperintensities. And then anything that will look like the brain will be isodense. So you can see the anatomy in a sagittal view is very good. Here you can even see the sulcus. You can see the sulcus. You can see the frontal lobe, the parietal lobe. You can see the corpus callosum. You can see the genu here. You can see the splenium. You can see what you call a cingulate gyrus. It has so much details. Here you can see the pituitary stalk. You can see the pituitary gland there, which is shiny. Look at the brain stem. You can see the midbrain there. Look at the pons. Look at the medulla. Look at the cerebella. So it's a very clear anatomical structure. And that's why we like the MRI. As when you compare it to the CT scan, the clarity of a CT scan is not very good. While in a CT scan, we use what we call density. So anything that looks like bone is hyperdense. Anything like brain is isodense. Anything like CSF is hypodense. So you can see here, the choroid plexus is hyperintense because it's calcified. So anything that looks like bone, which is calcified, is hyperdense. And that's how hematomas look like in this case. They look hypertense depending on whether the hematomas are fresh. So this is how an AVM looks like. AVMs are arteriovenous malformations. They are a conglomeration, or they look like worms, a bag of worms, very, very risky. And then you can have AVMs with an aneurysm. These are venous aneurysm. Aneurysms just mean a ballooning of the blood vessels. So AVMs are common. These are very dangerous. And we use what we call Spetzler-Martin classification. I'd like you to go and read about the Spetzler-Martin classification, which guides us in terms of operation. So vascular tumors are very, very common also in our setup. Now, in this particular scan, I'm showing you how an aneurysm looks like. These are what we call a brain angiogram. There's a balloon there, and these are the ones which can burst and give you a stroke. You can see this particular one is a CT angiogram. It's more clear. You can see a ballooning there. That's what we call aneurysm, which give you what we call subarachnoid hemorrhage. And this is a very risky pathology. You can see here we have what we call a giant aneurysm, very, very complex in terms of surgical approaches, because these are the ones we do what we call anastomosis of the internal vessels. you can anastomose what you call the internal carotid to the superficial temporal artery to bypass this huge giant aneurysm. You can also see it here in terms of a 4-vessel angiogram, that big balloon. This is what we call the internal carotid going up, then it branches outward to give you what you call the middle cerebral. Then this is the anterior cerebral. Then anterior cerebral, where it's coming to meet the anterior communicating artery. You see a huge balloon there, and that's a huge giant aneurysm. Very difficult to manage. So neurosurgery is enjoyable. You like I told you, you've got to have a family because neurosurgery can drive you to a situation where you don't have a family, number one. Number two, it can drive you into depression if you're not very careful. Number three, you need to have a lot of international collaborations to improve your skills. So I'd want you to also marry early in this class. I hope you guys will get into mentoring, where I need to mentor you to see how you can settle early in your family. Now, in terms of infections, infections are very, very common in neurosurgery. We normally have what we call abscesses. You can see multiple abscesses there in the brain. Then you can have what you call tuberculomas. Tuberculomas are solid tumors from TB. Normally, they are hematogenous spread. And then this can also be TB abscess. When you compare a tuberculoma and TB abscess, is an abscess has a capsule, and inside will be hypodense. So it shows you inside is a fluid cavity. You can have multiple of them. These are patients we worry about HIV status or immunosuppression. So in terms of infection, you can also have HIV-related infections. So when you're taking a history and a patient is exposed to tuberculomas, you really have to assess whether there are any other immunosuppressive diseases. Now, in terms of other infections, remember you can have fungal infections also. You can have other infections which are bacterial. And normally bacterial infections would come in from sinusitis. Patients who have sinusitis, or patients who have pneumonia, or patients who have mastoiditis, or infections in the ear, you really need to see them quickly, because those infections from the ear or from the sinuses are the ones which spread and become abscesses. Now, in terms of the spine is also a very important part of you. You'll see in a lot of patients with the back pain, cervical myelopathy. So degenerative diseases are very, very common. All right. Then we have infections. Then we have tumors. Then you have cystic diseases. Then you have what you call the spinal cord. All right. So this is where I'd like you to copy this particular word. All right. Let me see if I can write it here. It's a word which I'd like you to remember in capital letters. We call it ditch. Right? I know most of you have been ditched before. Let me see if how do I send? Yeah, I think I've sent.
We've seen it.
Seen it, eh? Now you might be told discuss the pathology of spinal cord diseases. Right? Discuss pathology of the spinal diseases. Or when you reach 6th year, we'll tell you discuss the management of a patient with paraplegia. All right, paraplegia is weakness of the lower limbs. And the word ditch is very simple. D will stand in for degenerative diseases. All right, and degenerative diseases are spondylosis or spondylolisthesis. All right, those are the degenerative diseases. Then you can have in a lecture. So we have degenerative diseases. All right. Then the second one, you can have infections. And I've told you infections can be bacterial, can be viral or fungal. Normally infections, we divide them into either acute infections or chronic infections. The acute infections are some of the ones I've explained to you, where it can be bacterial, like an abscess from a boil, all right, or even meningitis or sinusitis, which give you acute infections, which can come to the spinal cord, especially patients who are diabetic. Then chronic infections are the ones I've told you, which in chronic infection, we normally say the infection can be granulomatous or non-granulomatous. Granulomatous diseases would be like TB. Then non-granulomatous diseases would be like the other bacterial infections, commonly things like bacillosis, bacillar infection, or even staphylococcal or streptococcal infection. Then tumors can be either primary or secondary tumors in the spine. Now, when you think of tumors in the spine, I want you to remember this. The tumors can be intradural or extradural. When you talk of intradural tumors, it can either be intradural intramedullary tumors or intradural extramedullary tumors. What does that mean? When a tumor affects the spinal cord, we call that intramedullary. But remember, the spinal cord is inside the dura. So any tumor that is inside the dura and attacks the spinal cord, we call it intradural intramedullary. But you can have other tumors that are outside the cord, but inside the dura. So we'll call that intradural extramedullary. And I give you examples. Intradural intramedullary tumors would be the gliomas or astrocytoma, let's say, astrocytoma tumors of the spinal cord. These are glial tumors of the spinal cord. Then you can have meningiomas or what we call schwannomas, which are on the dura but on the inside. So these terminologies are very important because they'll reflect on your examination of the patient. All right. For example, when you have a patient with a tumor which is intradural, intramedullary, that patient will come in with lower limb weakness with spasticity because it will affect the corticospinal tracts. But if you have a tumor which is intradural, extramedullary, the tumor can be affecting only the nerve. So the patient will come with paresthesia. They'll be feeling numbness or one area that is locally affected. Then let's go to the C part of the ditch, which is the cystic diseases. The cystic diseases are water in the spinal cord. So you'll hear us talking about a syringomyelia. A syrinx means cavity. Myelia means cord. So you'll hear of a syringomyelia or hydromyelia, or sometimes you might hear of an arachnoid cyst. Then lastly, the H part are hematomas that result from spinal cord injuries. All right, so you can have a hematoma, that's a patient who had an accident, so he bled into the spinal cord, or you can have a patient who has an arteriovenous malformation in the spinal cord, or sometimes patients who are using aspirin, or patients who are on anticoagulants, all right, who are given anticoagulant and they bled into the spinal cord. And this can cause weakness of the lower limb. So I think I want you to remember the word ditch all throughout the years, but I'll continue teaching you and giving you some of the synonyms to help you memorize some of these issues as we go on learning. So in terms of the spinal cord, you can see in this particular one, you can see the vertebra is affected. This is more of a metastasis or maybe a tumor or an infection. And you can see it's likely to be an infection because behind here you have pus collection. The TB normally looks like this. These are patients who will present with a history of lower limb weakness. And on examination, what we really require you to revise is how to assess power, how to assess tone, you assess sensation, you assess reflexes, and the gait of this patient to come up with a diagnosis. So just as we finish our lecture, I'd like you to also know that neurosurgery is a very difficult field. I don't want you to be discouraged. I think some of you are artists. I don't know who would want to comment on this picture. I'm not able to see. Let me see if I can choose randomly on some of the participants who can share with me the reading in terms of this film. Now, this particular one just shows you how we rely on the higher power to control. And then down here, as you do neurosurgery, you need the nurses, you need other people to help you in the field of neurosurgery. You cannot do neurosurgery on your own. Neurosurgery is a multidisciplinary. We need neurologists, we need a physiologist, we need the ICU intensivist, and we need radiologists. So it's a field that works in as a team, like you can see in this particular film. And then lastly, neurosurgery, you must have passion. Don't chase in the money. You must work very, very hard. Yeah? It's going to take you another 7 years to do neurosurgery. After you finish your internship, you'll come and join our program, which is 6 years. We'll train you to be one of the best neurosurgeons. The ones we've trained here now, some of them are working in Canada. I have one student working in Canada. There's one working now in Botswana. There's one working now in Canada. And the other one has gone to work in Belgium. So our program is very, very popular. It's very competitive, but I'm looking forward to interesting you into this neurosurgery. And that's why I need to motivate you and see if majority of you can come back to join us in this wonderful field. So this will be the end of my lecture. And in the end, this is a famous place you'll visit in Israel once you qualify to discover many things that happen there. And most of the things that happen there are real. Eh? They're very real. And I'd want you to visit, and maybe some of you can ask me questions as we finish. So in conclusion, the idea is to introduce you to neurosurgery to make you understand the pathologies we have, number one. Number two is to introduce you to interest in neurosurgery, but we'll continue explaining to you as you learn the basics of history taking and the basic of examination. So I think that will be the end of my lecture. I'm looking forward to having questions from you. I'm in the department. Some of you can visit the department. I hope the internet was stable so that we can communicate. So any questions from the attendees or anything that want to clarify? I can see Kibet here. I can see Terry Esther. I can see Wycliffe. Kibet, can we hear from you? Any comments, any additions, subtractions? Kibet Jeremiah? Maybe.
Yeah,
Yes,
the lecture has been good. Yes. So I say thank you for the lecture. I don't have much to comment.
Okay, very good. Any questions? I want to ask any questions from the floor. Any clarification? Because neurosurgery is big, but I've introduced you. I hope I've aroused you some interest. I need to make sure, I need to get a lot of you to come in for neurosurgery. It's not as bad as you think. And it's a very, very interesting course. I can assure you, it's very enjoyable. If I was to be born again, I would still need to do neurosurgery. All right. So let's hear from Wycliffe. Wycliffe Geshoy. Any comments? Any questions?
I believe it has been an interesting class. You've introduced us to neuro, shown us that we need to have passion, and we look forward to more teachings with you.
Thank you. I want to teach you a lot. I want you to chase me in the theaters, come to the clinics, because also I'll teach you in the sense that you'll pass. I want all of you to pass. Really, I feel very sad when imagine you're just supposed to know history taking and examination. By the time we are taking you to a level of even this diagnosis or seeing a CT scan, if you see me giving you a CT scan in your level 4 exam, it means I'm giving you a distinction. All right. So the teaching I want to do now is to get all of you. I think I need another lecture to just give you the basics of chief complaint. How do you get a chief complaint? Number one. Number two, the history of presenting illness. Number three, we go to the past medical history. Number four, we look at family and social history. Then number five, we do what we call the systemic inquiry. Then from there, you have to give me a summary. Then after you give me a summary, is when you go now to the examination, which will be on examination, these are my findings, but you start with what we call the general examination, which is anemia, lymphadenopathy. You want to look at jaundice, all right? You want to look at finger clapping. How do you examine for finger clapping? How do you look at the pulse? Can you imagine in the last exam, I think it was a 5th year, we asked them, where is the radial pulse? You know, the radial pulse is normally here, all right? The radial pulse is here. And this student was looking at the radial pulse here on top. I don't know, are you seeing my screen?
Yes, we can
see. Are you able to see my
it.
screen? Yeah. Can you imagine somebody saying the radial pulse is here? All right, I don't know who taught them. And the radial pulse should be on the inner side, all right? Somewhere here. That's where, and then there's also the pedal artery on the foot. I mean, when you're not able to show me where you can assess the radial pulse, you don't even know how to do the blood pressure with a sphygmomanometer, the one we use with the mercury, or even the automatic one, the automatic machine, the automatic electric machine for blood pressure. Because you must know how to do the blood pressure and the pulse for examination. We call those general examination, then know how to do the temperature assessment. Then from there is when you go and assess the different examination areas that you need. And I'm telling you, we have maybe another 20 weeks or so. Oh, I don't think we have more than 30 weeks. And I think if I follow all of you, I'll be able to really guide you. And I should have 100%. I want to have 100% pass in surgery this year. Right now, I think I have about 4 students who are repeating 4th year. They're doing a supplementary this week. And then next week they do the clinical examination. So I don't know whether maybe some of you can come and get involved on how we examine so that you see really we are very fair. It's a very simple examination. But I was once a student and I know examinations can be very, what do you call it? They're very tense, very anxious. So I would like to really know what the problems are. And the earlier we communicate, the better. You know, before that I was in the dean's office. Then I had a lot of, I was acting. Then when I came back, I'd left my colleagues here. And right now I'm seeing the timetabling is not as good as I would want. So I'm working with Khan, and please all of you get involved so that we make sure we teach you better. Any final comments? Khan, maybe I leave you to give us a final comment. Any other questions you'd want to ask? I think Khan was using.
Thank you so much, Dr. Kiboi, for your wise advice to us growing doctors. I just want to let you know that this is by far the best lecture we've had in 4th year till now. So we appreciate your time and your words. It's of a lot of value to us. And we appreciate also that you really want 100% pass rate. It's really good to hear this from a lecturer. And
yeah, that's okay.
Thank you so much.
I would want that.
Thank you so much, Doctor.
So we can hear from Akwenda Manasseh, then we close. Akwenda Manasseh, and then we can hear from one lady. Yeah, I like being gender sensitive. Akwenda Manasseh.
Okay, good afternoon, Doc. I've really been impressed by your wise, inspiring talk, and we are looking forward to be great neurosurgeons in future. Thank you.
Thank you. So I want one of the ladies, a volunteer, to tell me, because we're also interested in ladies. We want ladies also to join our program. So it will be very important that I hear also from the ladies, because they are part of us. We have the lady I'm telling who is a neurosurgeon in Canada is a lady. She's called Modoni. She was one among the second ladies in our program. Then we have Sisanya, who is a neurosurgeon now in JKU CAT. We have another neurosurgeon. I'm the one who helped her to go and do neurosurgery in South Africa. She went and did South Africa in Durban. She's called Susan Karanja. She's now employed in Kenyatta. So then we have Tracy, who is working in the Ministry of Health. She's attached in our program. So I really would want also to encourage. This year, I took a number of ladies. There's one called Agnes, who is a captain. She's a captain in the army. She's based in Nanyuki, but she didn't get a scholarship. So she has postponed her coming in for neurosurgery this year. So I would like to hear from one of the ladies. Can I have a volunteer, please? Any ladies to volunteer, or I look around, I select one. There's somebody called Ann Nyabuti. Ann Nyabuti, are you still there? Somebody called Aisha Naji. Can you hear us? Aisha Naji, no, there. Barbara Samba. I want the ladies to talk.
Maybe I can speak, Doc.
Okay. Thank you so much. Effie.
Yeah, I just want to say thank you for the lecture and for the inspiring words. You really stirred us up. And yeah, this is something that you've really stirred us up. We are actually considering venturing into this field. So thank you so much. We are truly, truly grateful. Yeah.
Welcome. So I think have a great day and enjoy this noble profession. And I'm looking forward to, please come and visit me in the department, all of you, when you have time. It's busy, but my office is open. And let's see how I can improve your teaching in fourth year. Please be all involved. Don't leave it alone on CAN. Let's see how we can improve your teaching in this academic year. Thank you and have a great afternoon.
You too, Doc. Have a great afternoon.